It is my esteemed honor and privilege to introduce the 2020 invited presidential guest lecturer, Dr. Gustavo Oderich. Dr. Oderich is currently at the University of Texas Health, where he holds the following positions. He is professor and chief of the Division of Vascular and Endovascular Surgery. He is the director of the Aortic Center and Program, and the director for the Advanced Endovascular Aortic Fellowship. Dr. Oderich was born and raised in Porto Alegre, Brazil. As a young man, he was a very accomplished sailor and participated in races. I haven't been able to confirm this, but I believe he was on the Brazilian national sailing team, or at the least competed for a spot on that team. He obtained his medical degree in 1995 at the Universidade Federal do Rio Grande do Sul and stayed there for his general surgery residency. He came to America and won a research fellowship at the University of Utah from 1998 to 1999, and then restarted his American surgical training at the Mayo Clinic in Rochester from 1999 to 2004. He stayed there to complete his vascular surgery fellowship in 2006. In early 2007, he completed a 3-month advanced endovascular fellowship at the Cleveland Clinic and got to rub elbows with Roy Greenberg, much like I did personally in 2001. Only until recently, and as long as I've known him, almost all of Gustavo's professional career has been at the Mayo Clinic. He has served on numerous committees and has won too numerous to count accolades and awards, to include the impressive 4-time winner of Teacher of the Year Award in the Department of Surgery. He is a member in good standing of 15 different societies, and as of today, 16. He is a reviewer or editor of 63 separate journals. His academic accomplishments are simply breathtaking. Literally hundreds of presentations in the Americas and Europe, 38 visiting professorships in 10 different countries, over 300 peer-reviewed publications, 3 books, 127 book chapters. From a professional standpoint, Gustavo is incredibly driven to excellence in himself and those around him. Technically, he is very gifted at what he does, extremely innovative, and has that keen sense to see in 3 dimensions on a 2-dimensional screen. His research programs and academic productivity are incomparable and impressive. As a young surgeon, he learned to handle constructive criticism well to better himself as a physician and surgeon. On a personal note, he is a devoted and proud father and husband, has a very good sense of humor, loves good red wine, and I mean good red wine, and is cosmopolitan in his views and dress. He loves European styles and is truly Brazilian at heart. I'm delighted that he accepted my invitation to be this year's presidential guest lecturer, and I'm also delighted to present him with honorary membership into our society. It is sad that we can't spend time with him in person in Santa Monica, but perhaps another time. An open invitation will remain to Gustavo Oderich forever. Past presidents, executive council, members, and guests, please join me in welcoming Dr. Gustavo Oderich.
Ben, I would like to thank you so much. I'm so honored. This is a very special thing for me because when I came to the United States, participating at the Western Vascular Society was my very first opportunity academically. I was under Dr. Peter Lawrence, and I remember very well that the biggest deal was to get a paper accepted at the Western Vascular Society. And I was very fortunate that I had the chance to be there in Lake Tahoe in 1999. I'm even more honored because I consider you just such a special person and special academic surgeon. And to be selected by you among this list of very prominent faculty to be your guest lecture, is like a huge honor. So I hope I make justice to this. I intended to do a talk that will review some of the historic footsteps of aortic surgery. And I have to disclose and disclaim that this talk really does not make justice to most people. I just hope to keep in a timeline. We have made a substantial amount of progress if we look back in the last 3 decades and think that when we read the Rutherford, the Bible of aortic surgery, the chapter of thoracoabdominal aneurysms had just 4 pages. We have made substantial progress. And that is because each one has stood over the shoulders of giants in the past and have helped to evolve this specialty, understanding the limitations of previous techniques and improving upon their own results. It really all started in the mid-50s, and although there is some dispute on who did this or that first, pretty much like we do today, the very first acknowledgement of a thoracoabdominal aneurysm using this specific word was by Charles Robb in the Royal Society of Surgery as a lecture. Shortly after that came the very first report in the United States, and that was an extent 4 thoracoabdominal aneurysm by Dr. Oderich in California. And then after that, Mike DeBakey and Denton Cooley reported a patient they had treated in January 4th of 1953 for an extent 3 thoracoabdominal aneurysm. But probably the way we know it, these operations became really more developed in the Crawford era. And that started in 1974 when Stanley Crawford reported his first 23 patients using the inclusion technique. And this is a photograph that Dr. Safi shared with me when Dr. Crawford performed his 500 thoracoabdominal repair. And please just understand the timeline here. He was 10 years into this practice. And in the subsequent 10 years, he did another 1,200 cases. It's nice to see this illustration of him as a superhero beating the heck of these thoracoabdominal aneurysms. So what is the benchmark we have to meet nowadays to beat open repair or to compare itself with open repair? This is a photograph of Javier Sotomayor when he bet the world record in 1993, which is still to this date unbeaten. Actually, despite all the advancements, there has not been a whole lot of improvement in mortality. If we think back that Stanley Crawford was operating in the 1970s and 80s and achieved a mortality of 10%, and that recently the mortalities by Dr. Coselli, Cambria, and others hover between, really 7 to 16%. We haven't really seen a lot of improvement in mortality. And when we look at centers that perform low volume, the mortality rate is staggeringly high. So this is an operation that should be done in centers of excellence. And I think that is a message that resonates with most of us. But even in centers of excellence, we look at this recent publication by Akiko Tanaka, one of our superb fellows here, on over 2,000 patients, and they look at the results on patients younger and older than 50 years old. Patients older than 50, which comprise 86% of the cohort, had a mortality of 17% with a rate of disabling complications of 40%. What about endovascular therapy? I think there were 3 pivotal events that have led us to be able to do what we do in the way we know it. The first one was the striking development of percutaneous angioplasty by Dr. Charles Dotter in 1964. He is considered the father of interventional radiology. Subsequent to that, Andreas Gruzzi performed the first coronary angioplasty, and that was important because sitting on the audience of his very first presentation was Dr. Julio Palmas, who in 1985 came up with the patent of balloon expandable stents. Needless to say, he sold that patent for $500 million in 1989. And that was incorporated as the design of over 80% of the coronary stents and general stents at the time. Now you may ask, why is this important? What does Chernobyl has to do with this? And indeed, at that time, on April 1986, I was 15 years old, and I was sailing for the Brazilian team in the World Championship of Optimists in Spain. And meanwhile, in Russia, we have the very first nuclear accident that's of large magnitude. But a week before that, the very first endovascular aortic repair had been performed by Dr. Volodys. And we never found out about that because of the Iron Curtain. And we're now celebrating the 30th anniversary of the first TEVAR in the Western world. And indeed, Dr. Perotti performed the very first repair in this side of the world, and I think is responsible for the dissemination of the technique in many countries, including the United States, and the revolution that started there after that. And we know the story. Mike Dake performed the first TEVAR in the Western world in 1992. Remembering Dr. Volodys had done this in 1988. And after that, other techniques came by, and the indications have expanded, including the use of TEVAR for dissections. That has resulted in a remarkable change in the way we treat this disease, with an increase in the number of operations, likely because we now had a less invasive alternative, and a remarkable decline in the mortality rate when we look at large data sets. So endovascular therapy has expanded beyond aneurysms to involve trauma, dissections, acute aortic syndromes, and other rarities. But there are still areas of clinical need. And that's what I want to focus on the next minutes, particularly with incorporation of the renal and mesenteric arteries. So the very first report was done by an interventional radiologist. And I want you to keep that in mind, that actually radiologists were the very first to make the steady progress towards incorporation of vessels. This was by Jay Park in South Korea.
I don't have it.
Again, given the work of Thomas Brown, Michael Lawrence Brown, and David Hartley, at that time the device was called HLB, Hartley Lawrence Brown, which then led to the development of the Coop bifurcated design as we know it. Working in the lab, John Anderson was able to do the very first clinical implant of a manufactured fenestrated device, and this is actually an angiography of his case. Note there is a single fenestration. There is actually no alignment stent. Soon after that, several have found out that the use of alignment stents was key to diminish the loss of target vessels. And then several improvements came by. The very first fenestrated was mounted on a bifurcated device that was changed to a tubular design to allow migration of the bifurcated device without compromising the targets. The fenestrations became reinforced. The bare metal stents changed to covered stents. Diameter reducing ties were added. And in the last decade, preloaded wire systems and lower profile fabrics were added. Meanwhile, surgeons were trying their best to use these less invasive techniques in more complex aneurysms. And one of the first steps forward was by Bill Quinones-Baldridge at UCLA, with the description of what is known today as the debranching or hybrid procedure. And indeed, several centers have achieved superb results with that. But I don't need to tell you that others that have applied this technique in the highest risk patients, that includes the Mayo Clinic, have had high mortality rates. And this technique has fell in disfavor in most centers. In 2001, working on his office, and I think Darren Schneider was his fellow or young staff, Tim Schutter modified the device, which is shown here, and was later sterilized and used in a patient with a thoracoabdominal aneurysm. And that led to the development of concept of directional branches and the T branch that we know today. Now, Roy Greenberg in 2003 was treating a patient and decided to raise the landing zone by placing stents in the renal arteries. He described this as if the infrarenal neck was deemed too short for sealing. A slight longer neck was created by advancing the graft material a few millimeters over the ostia. And that gave birth to the parallel stent graft technique, which we know has received many names: chimney, snorkel, periscopes, and it's fair to say Thomas Larsson, Frank Criado, and Mario Lachat had a lot to do with the development of that. With time, the ambition to get more complex anatomy led to the development of graft-to-graft parallel grafts by Armando Lobato with the sandwich technique and Dr. Kazirajan with the octopus technique, as shown here. And the best data on that comes off the Pericles registry, which Jason Lee, Dr. Donas, Dr. Lachat, and Dr. Vive spearheaded this initiative with now over 500 patients. And on this data set, you can see a mortality of 5%, although the elective mortality was 3.7%, a stroke rate of 1.7%, and a type 1 endoleak rate of 8%. I want you to remember these numbers when we go to talk about other techniques to treat complex aneurysms. And also that most of the series with parallel grafts are focused on pararenal aneurysms with an average number of vessels of 1.7 per patient. Parallel grafts, as we know, is actually very useful technique that should be in the armamentarium of every surgeon. But the main reason it's used nowadays in very high numbers is due to the lack of access to manufactured devices, also to the cost of these devices, and to the unavailability of standardized training. The main drawbacks of parallel grafts include the fact that you need multiple upper extremity shifts that may relate to the risk of stroke. These devices oftentimes are not made to be fighting radial force with each other, which may lead to occlusion, and of course, the known gutter endoleaks. Now, the first attempt to bring fenestrated graft to the masses was done by Renaud Flacker and Krassi Ivansev with a description of the technique of modification using a Zenit stent graft. That was a very important paper to me because when I was forced to do this for the first time, not only I read their paper, but I took the initiative of calling a few people around the country and in the world, including Dr. Ivansev, to discuss how he actually did it. Ben Starnes, our Western Vascular Society president, played a very important role in this. He has done his first case modification on April 5th of 2007. He coined the term physician-modified endovascular graft. I think that is very important because surgeon-modified graft is not an inclusive term and in fact does not make justice that the very first modified grafts were done by interventional radiologists and not surgeons. And he also pioneered the concept of using 3D print model, which led to the Aortica company and now to a very robust physician-modified IDE with 177 consecutive patients with no type 1A endoleak and a 97% 5-year freedom from aortic mortality. And he was just granted the approval of the FDA to expand the IDE to 300 patients. Actually, I came back from Cleveland April 1st, returning under the supervision of Roy Greenberg, and waiting for me was Peter Glavisky with a patient that had a symptomatic complex abdominal aneurysm with a previous necrotizing pancreatectomy, multiple pancreatic necrosectomies, eventually a hernia with a mesh. And he asked me, Gustavo, you need to treat this patient with a fenestrated graft. And I said, well, Dr. Glavisky, we don't have a device. We'll probably not have a device for years. And that's how I happened to dig through the literature and did my very first repair. And that was a 4-vessel modified fenestrated repair. And you can see here the CT angiography of the very first patient with significant shrinkage. I spent then several years describing ways to modify device with the description of fenestrations, mini cuffs, directional branches, recently inner branches, diameter reducing ties, and preloaded wires. And I think, again, this is a very useful technique that should be part of the armamentarium. And here are some of the contributions, again, not making justice to everybody, including the technique of sequential catheterization described by Carlos Timoran. But in the United States, things started really to change in the April of 2012 when we had the first manufactured device approved. And for some of the European colleagues that are listening, a key difference in aspect to what they have in other countries is that the device has a maximum of 3 fenestrations, 2 of the same type. So it's really designed for short neck infrarenal and juxtarenal aneurysms. I had the honor to step in on Dr. Greenberg's role of a PI in terms of writing the results of this trial. You can see here the first description of the 67 patients with 1.5% mortality. Again, a very low rate of type 1A endoleaks, similar to what Dr. Starnes reported on his IDE. And most recently, you can find this now on PubMed. We reported the 5-year follow-up with a mean follow-up of 46 months. 95% of the eligible patients were followed clinically and by imaging. And we did not have any other type 1A endoleak. We had 1 type 1B endoleak, 2 device migrations, and 4 instances of sac enlargement. So the freedom from aneurysm-related mortality was 97% at 5 years, identical to what Ben has just described. And the primary renal target artery patency was 83%, but I would remember you that this was done with bare metal stents for the most part, and not with covered stents. Now, this has taken off in the US with approximately 2,000 cases a year. You can see here, most of the designs are 2 fenestrations and a scallop. But when we look at the suitability of this device, you can see that in blue, 2/3 of the patients do not qualify for the Z-FAN device. And the other word of concern, which is actually similar to a presentation that was done today by the group of Ben, is the issue of neck enlargement. You can see on this example done at the Z-FAN trial, the enlargement at level of the renal arteries from 33 to 40 millimeters. And this is a busy table, but I'll point out to this corner of the table where 67% of the patients had enlargement at the level of the renal arteries in 5 years for a mean of 6 millimeters. So imagine fast forward this with the concept of chimneys or other techniques that emphasize the use of short neck lamps, how that would translate, and that I think is a very concerning topic. So coming back to the lines of Dr. Greenberg, the single most important step for a successful endovascular repair is neck selection. And if you obey to this saying, I think you will have very good results and you will have a more durable repair. So it's really about looking at the aorta on a center line of flow, identify segments with parallel wall, and selecting good lengths of normal aortic segments. And that's where we are today. And I think these patients can be grouped in 2 risk groups. Essentially, extent 4 thoracals have nearly identical outcomes as juxtarenal and paravisceral aneurysms. And then you have a separate group with extent 1 to 3 thoracals, and we'll see probably most of the clinical trials to be designed using this risk stratification. So where we are at today, so what can actually be done today? So we have a number of devices that are currently under investigation by numerous companies, which is a good thing. Finally, I think several of the players have realized this is the next step. We have the Gore-Tembi device already on a pivotal trial. There is at least 3 other trials underway, the Cook-Ziffen Plus, the Thoraco Plus, and we'll be seeing very likely trials by the Medtronic group, CryoLife, and Terumo Aortic with their devices in the next years. The Gore-Tembi repair, the first implant was by Pieri Galvani using the retrograde design in September of 2014. And the antegrade design, we had the honor to do it at the Mayo Clinic in March of 2016. This device has 4 directional branches called by Gore as portals with a preloaded wire system which allow you to sequentially deploy, and it does add a constrained mid-segment which allow you to maximize space to catheterize the vessels. The early feasibility study was a small study just to evaluate really the feasibility. There was no mortality, dialysis, or spinal cord injury. Technical success was high. And this led to the pivotal trial, which is currently underway. And although I think most of the off-the-shelf concepts make sense, I think it's important to note that it will be very difficult to incorporate all these variations in anatomies using directional branches. I put this example here. These are 2 patients treated for similar issue, which is a thoracoabdominal aneurysm with an upgoing oriented renal artery. And in one side, you see this done with a fenestration, which is relatively straightforward. And in the other side, done with a directional branch. And that is, it can be very difficult, requiring innumerous techniques of bailout, here shown, like a snare ride or balloon-assisted stenting, to be able to navigate that stent into this difficult upgoing renal artery. So I think that the future lies also on patient-specific devices where we'll be able to adapt the stent to the anatomy of the patient as opposed to the patient into a specific design of a stent. The other thing to keep in mind is aortic coverage, because that relates directly to the rate of morbidity and mortality of these procedures. You can see here 3 examples of an extent 4 thoracoabdominal aneurysm treated by a Ziffen Plus or a TAMBI or a T-branch. And although we are sometimes obliged to do this to cover 12 centimeters of normal aorta, you certainly don't want this to be your routine, and I think it's fair to say it will translate into a higher rate of spinal cord injury. Now, when I contemplate on our program, we went through phases where we were doing a lot of modifications, phases where we were very attentive to spinal cord ischemia protocol, and then eventually were blessed with access to manufactured devices via an IDE. And by the time I left Mayo, we were just short of 700 cases done. There has been a learning curve, which I would like to share with you. You can see here that our mortality has declined when we divide in quartiles on this preliminary analysis of just 330 patients, and so did the rate of major adverse events and early reinterventions. And when we look at the cumulative sum analysis, and what is that, is a cumulative rate of complications. And of course, as you do more cases, you're bound to have more complications, but what matters is the rate relative to a denominator. And you have here the expected rate in the literature and the below expectation rate. My experience started to shift when we crossed 33 cases. It plateaued at 100 cases. And we really started to get better than the reported results in the literature after 200 cases. So there is a learning curve that has to be considered, particularly when we look at the outcomes in the literature. The other aspect to emphasize is the issue of radiation, because these procedures carry very high dose of radiation, at least about 15 times that of a standard repair. And because we're more and more becoming endovascular surgeons, you can see here my personal trends at Mayo, where by the end, the tail end of my career there, I was like an over 90% endovascular surgeon. So I think that investing in a fixed hybrid room, I call this your work horse, and you want to have a good horse when you go to battle. that you have advanced imaging capabilities, to be able to do these procedures with better technical result, being able to assess the technical aspects of the procedure using a fusion and a cone beam CT, but also with a much lower dose of radiation, leveraging several of the features that are available nowadays. When we look at our experience, again in quartiles, and also as we shifted to different manufacturers of hybrid units, you can see here that we are down to 1/3 or where we started in terms of exposure for the patient and also for the operator. Now, currently, most of the patients we see are included in a prospective non-randomized study. A few aspects of this study is that it includes 2 arms of thoracoabdominal and arch aneurysms. I would say pararenals are included on the arm of thoracoabdominal aneurysms, although they are classified differently. And we pay a lot of attention to the quality of the data, to the questionnaires we do for quality of life, to the monitoring we do, and we try to keep this as the highest possible level we can. This is the referral pattern before I moved to Houston. And just before I left, we had 430 patients included in the IDE, and you see the data here on 405 patients, including 154 extent 1 to 3 thoracoabdominal aneurysms. A few aspects to be emphasized here. The average age is 74 years old. These patients have substantial rates of comorbidities, including a high rate of coronary artery disease, a high rate of stage 3 to 5 chronic kidney disease. That is important because it is the most important predictor of mortality for open surgical repair. And we have not relied in one single design. I want to share with you several variations of design that we have used. Here's a 74-year-old male with an extensive post-dissection aneurysm involving the arch and the thoracoabdominal aorta. These patients are treated in stages. First here with a 3-vessel arch design. Just to share a short clip of the procedure, we use fusion. We use the CO2 flushing of devices as described by Thilo Koppel. We do flush the CO2 out with saline. And you can see the device advance now across the aortic valve and a guide catheter in the left coronary artery, puffing contrast to be able to deploy this as precise as we can using rapid ventricular pacing. We do use a cervical approach to sequentially clamp the carotid arteries, and we document cannulation using a variety of the techniques, but I'm very fond of the intravascular ultrasound for that. After we place a self-expandable stent in the carotid artery, we do the angiography, flush the sheath, we close the arteriotomy, and then repeat the steps in the contralateral side, shown here. Again, with intravascular ultrasound of that inner branch and stenting to the left carotid artery. And finally, this device has a preloaded catheter, which allows you to do the subclavian branch from the femoral approach. The second stage is done with a fenestrated device. This was done with a device that has a preloaded renal catheters, which allow you to do that via the ipsilateral side of the device. Again, we use fusion for this segment of the operation as well. And note here that the true lumen is quite compressed, but I have gone nowadays to use actually a wider device rather than a narrow fenestrated device, and I just basically, similar to the stabilized technique, would use a balloon after cannulation of the device to basically disrupt the septum in that segment and allow full expansion of the device. This preloaded wire system, again, allow you to catheterize the renal artery through the ipsilateral side, and that's what we are doing now on this segment of the video, working with a glide wire and a Campi catheter, advancing into the renal artery, exchanging that for a Rosen wire, and then positioning a stent ready to deploy on the renal artery. And in the interest of time, I'm not going to show the other vessels, but just the final result of this using a cone beam CT and a selective angiography of that left renal artery. Now, you can be quite versatile with these designs, and here is an example of a patient with a ciliomesenteric trunk, which is very short and very wide, and you cannot seal the branch into that trunk. So we ordered 2 directional branches on this case, and what we did is selectively catheterize both branches simultaneously, and then did the kissing balloon, old kissing balloon style here on the celiac axis to be able to finalize the repair. Another example where you have to apply open surgery to render this patient suitable. This is a patient with 2 right side renal arteries that are very small size. And on this one, I use a modified ex vivo technique, which was taught to me by Tom Bauer. We clamp the renal vein, do a small venotomy, and we control the ureter with a silastic vessel loop to avoid retrograde blood flow to the kidney. And then you take your time rebuilding this renal artery with a vein graft. And here is the bypass to the renal artery and subsequent repair using now a 3-vessel fenestrated repair on this patient that also had a chronic dissection. You can see flow here into the renal artery on this angiography and cone-beam CT. Another example of an innovative way to do it is a patient with a chronic dissection where the right kidney was isolated, and for that we use a new preloaded wire system that allows access from the brachial approach, leveraging the compressed space of the true lumen and also allowing you to, as shown on the video here, use a reentrance catheter to break through that membrane and connect the branch into that right renal artery. Given that we were not able to navigate that through the small reentrance that the patient had there, we had to create a new one. But again, being able to do that without complete deployment of the device, I think was the key on some of the patients that have difficult anatomy. Another example of a patient that had an intercostal patch was not very large. So in this case, we elected to actually request a design that had a retrograde branch. And if this eventually grows, that it can then be occluded with a plug. Another example of a patient after an open repair who developed a large intercostal patch, and that was treated with a 3-vessel branch device from the brachial approach of quite difficult anatomy, but a solution that allowed us to do this in a less invasive way. And now I fear this is going to become an epidemic, which is the use of Z-fan device off-label with inadequate anatomy. You can see here a patient with a thoracoabdominal aneurysm referred with a large type 1A endoleak, treated in 2 stages. And this is indeed a very difficult task because of the significant amount of metallic artifact and the difficulties to actually navigate a fenestrated inside a fenestrated repair. So with this, to end with the final results, you can see here our IDE, the 30-day mortality on 405, now 430 patients was 1% with 4 deaths. That includes a rate of permanent dialysis of 1% and a spinal cord injury rate of 4%, reaching up to 8% for extent 1 to 3 thoracoabdominal aneurysms. Patient survival at 3 years was 79% with a freedom of aortic-related mortality of 99%. Target vessel patency is excellent at 97 and 99%, and freedom from branch stability also 94%. But there are failures. There are failures, and I would say early on, these are due to technical issues, which I think should be avoided with cone-beam CT. Instant restenosis and some integrity issues can also play a role. Our freedom from secondary interventions was 72% at 3 years, although the vast majority of these were minor reinterventions, most of them done by endovascular means, and I think that that is important to give the credit of that to endovascular techniques. Here are some examples of the most common reinterventions: instant stenosis that can usually be treated by placement of an additional stent, Integrity problems are actually infrequent, but can happen, such as a fracture on this ICAST stent, which was treated with a realignment. And again, type 2 endoleak, we are very conservative on indicating repair, but sometimes that does need to be repaired with embolization. Freedom from minor interventions was 82% at 3 years, and freedom from major aortic interventions is 90% at 3 years. We also look at quality of life changes, and we noted there were no difference in quality of life scores on patients who had or didn't have a reintervention. Lately, we have an initiative of 10 sites that have IDEs, the United States ARC, or Aortic Research Consortium. There is a little bit of change in the recent months with PIs moving to other institutions. I think this is something we're going to see over time. This is a preliminary review with 1,300 patients in the ARC. And you can see here the overall mortality is 2.1%, including a mortality of 2.1% in the most extensive groups, which challenges certainly the results of open surgical repair. I think ultimately what we are trying to do is to prevent aortic-related death. And when we look at this metric, there is no question that fenestrated branch endovascular repair has become, in my view, the first line of treatment. And the issue now is to become it more disseminated and more available. Having said that, open surgical repair is also here to stay. And I think it has its role on patients who have genetically triggered aortic diseases, particularly those that have not been treated yet, and perhaps some of the very young patients, or those that do not fit the anatomical criteria. Now, in conclusion, fenestrated branch endovascular repair has been widely adopted in many centers and has the potential to significantly decrease the morbidity and mortality of complex aortic repair. Reinterventions are needed in 20 to 40%, although most of those are done by percutaneous endovascular approaches, often as an outpatient. There are several investigational devices that are currently now on phase of trial. We are very hopeful these are going to become available and eventually change the landscape of how accessible these are. And I think are going to be certainly more and more incorporated in the practices of vascular and cardiovascular surgeons. Thank you very much. It's truly a privilege and an honor to be part of the meeting as your guest presidential lecturer. Thank you.
Thank you, Gustavo. That was absolutely phenomenal. I knew you wouldn't let me down. That was just great. I want to read to you some of the comments on the chat box, which has exploded with your presentation. So first comment is from a medical student, Taylor Ward, who said she loves the watercolor effect of the portraits. Overall, a very gorgeous presentation. Next is from your friend, Peter Lawrence. Gustavo, you have made all who have worked with you very proud, as well as the entire specialty of vascular surgery. Even more important are the many patients who have benefited from your pioneering work. You are young enough that you have many more innovations ahead, and we are all looking forward to hearing about your future pioneering work. Great talk. Good luck in your new life in Houston. Best wishes to Thanila and your children as well. Peter Schneider writes in, this was an awesome talk. Absolutely fantastic. Dr. Jordan Stern says, great talk, Dr. Oderich, and welcome to the Western Vascular Society. Do you think this technology should eventually be disseminated to all practicing vascular surgeons like EVAR has, or will it be kept only at high volume centralized centers?
So I think that this should be probably become more available, and in practical terms, is going to become more available in centers that have the structure, you know, around this, including the anesthesia staff, the nursing staff, and also the capacity to absorb the costs of this therapy, because, you know, this is a very costly procedure. At the end of the day, there is no question, then, that if we look at the outcomes of mortality and morbidity, the more volume you have, the better the outcomes, and also that there is going to be a learning curve. So with that in mind, probably is the right thing to do. But what defines a center is I think that will need a lot of work and help from societies and from the centers itself. I think in Europe they have that going a step ahead of us. It's probably going to come from the payers as well.
Yeah. So our current SVS president, Dr. Ron Dahlman, writes, outstanding presentation, Gustavo, tremendous addition to this year's meeting. Thank you, Ben, for inviting such a capable and inspiring surgeon speaker. Peter Schneider chimes in again and says, question, why has it taken so long? This has been an unmet need for at least 15 years for manufacturers to come up with programs and devices that would provide inclusion of more patients. Why has it taken so long?
I think, Pete, you are hitting the very important nail, and I think that there are several to blame. First, actually, the industry of failing to see that you have to stick to the rules with the FDA, and it's very evident that the FDA wants to see companies investing on the side branch as well as in the aortic component, and not only the aortic component. So that's what I think Gore has learned the lesson well. And, in fact, it's probably going to become the first available. And it's really because they understood the pathway and invested the time on the bridging stent. And I think that the others are learning that now and are going to invest the time on that. But
yeah. So Dr. Vanita Chandra says, great talk as always. I'm interested in your increased use of IVUS. Is this to help determine if there is any compression or kinking of the branches?
Well, Vanita, I have used mostly to document where I am in the device. And, I showed the example of the arch. Those inner branches, it can be tricky to document you're in the inner branch. You can use a balloon or a sauce catheter. I found the IVUS to be very reliable. And I think you can apply that. Carlos Timaran has used widely to apply that during the deployment to guide in relation to the vessels. And I think that, again, another example of the more you use it, the more you actually become confident about it. And for disclosure, I'm not a wide user as Carlos is, but I think it has a role.
So Dr. Dahlman chimes in again and says, just as spectacular as your presentation at the 2016 VAM. At that time, 127 consecutive cases with no deaths and no spinal cord ischemia. Congratulations on your continued success. Dr. Nitin Singh says, excellent talk, beautifully presented. Does the consortium have experience or results of those patients with genetically triggered aortic pathologies?
We are starting to have, Nitin. Most of those we have done in the setting of a previous Dacron graft that has failed into a patch. We're actually just submitting a paper to the JVS from multiple centers from Europe as well, about 30 patients with intercostal patch aneurysms. The majority of them have genetic disorders, and the results in those are excellent. And I think we are learning also that the distal landing zone is also not as important, because the biggest fear with genetic disorder is that the retrograde dissection across the arch, and that's the issue of landing on the native aorta, And distally, there are other ways we can bail that out, even with a hybrid repair to deal with a target that is degenerating if you need to do a bypass. So we'll see more and more of that.
Dr. Shireen Shalhoub says, fantastic talk. Good luck with your new move and new chapter. Dr. Andy Barleman says, excellent talk. Regarding your IDE, how many patients have been excluded and why? Have your anatomic criteria changed with newer techniques and tools?
Andy, that's a good question. I have excluded, I don't have the fixed number, but I can tell you that we were doing about 100 a year, and every year there is at least 10 to 15 patients that I said, go live your life. This is not for you. I mean, patients that had cancer, that have limited life expectancy, very advanced pulmonary or cardiac disease, very advanced renal disease. And then we have the anatomical limitations, the shaggy aortas, the multiple small renal arteries. So I think that on the overall practice, there is a good 20% of the cohort of patients I see that are a no, that I think that it's not a good idea to proceed, or I say no. So I am very picky with that, but I don't want you to get the impression also that we have not done high-risk patients. We have treated patients that I literally feel, I'm doing the wrong thing. Maybe I'm pushing too much. It's not an easy thing to figure it out. I was told once by Peter Glovitsky, that the toughest step on your career, Gustavo, is the judgment of when not to operate.
Yeah.
And I think that
Absolutely.
it's tough to write in a book, but that is the eyeballing of saying, no, I'm not going to do this, is the toughest step.
That's great. Roy Fujitani says, outstanding talk. Exciting to see how this technology is continuing to evolve in improving the care of our challenging patients. Thank you. Misty Humphreys says, do you think that all aortic patients should be required to be in a registry the way TCAR is set up? Do you think this could push practitioners to move from going off IFU to using a fenestrated or branched graft to help decrease failure rates long-term and improve outcomes?
I think, Manfred, that if you are doing this in large numbers, you should keep a registry format to document your results, and you should report it. And I'll be very puzzled to see what's going to happen with the outcomes of fenestrated on large data sets like the VQI, NSQIP, etc., given the fact that a lot of this is done under outside IFU and also mixing modifications with manufactured devices. And when we look at that data set, we have to be mindful of the fact we don't really know what is the anatomical criteria physicians used and how much they actually push the limit. But it's probably not going to be as good as a result of an IDE like shown by Ben Starnes. And in fact, he kind of nailed on his own institution when he shows the outcomes of the ZFN versus his IDE. Of the adherence to this IFU is what makes it you to achieve results that are outstanding.
Yeah. Dr. El Khoury says, Dr. Oderich, thank you for an inspiring talk. What do you think constitutes the best training platform for residents and fellows as these repairs become both more complex and more accessible?
Steph, I think that I'm very fond to, I'm very blessed that I've trained, I think, with the best people that I could ever ask for, in the front of open surgery, the Peter Glovitsky, Ken Cherry, and Tom Bauer, and then on the endovascular, Sean Lydon, Dan Clare, and Roy Greenberg and others. So I'm blessed with that. And I think, to me, the 3-month experience I had in Cleveland changed my whole career and the way I saw things. Mm-hmm. And actually, we have Sud Kohan here on the audience, and I can tell you, if you ask him, I'm sure his experience working with us there has changed the way he sees things. And I have been very proud of his career as well, and many others. And I think that that's what's going to happen with both endo and open, is that we'll have these mini fellowship paradigms. If you want to be truly dedicated to that, you probably should seek that additional experience.
We have just 2 more quotes, and they are from Mike Conti, our next president of this society. Combining innovation with ongoing critical reflection is what characterizes your outstanding work. Thank you for this inspiring talk. And then finally, Dr. Mitchell says, I think in Portuguese, that you're an American hero. So, Gustavo, thank you very much. I know it's quiet in your office there, but everyone is clapping. All 338 registrants are clapping. And there is your gift from the Western Vascular Society. So thank you very much. Really appreciate it.